series in The Lancet about a year and a half ago, and these are reasonably effective in depicting mild versus cirrhotic disease, but they don't at this point replace liver biopsy. And in fact, when we look at the things that have been associated with progression, we find that older age is associated with more progression, longer duration of infection, men tend to progress more than women, iron overload, whether it be hemochromatosis or secondary iron overload, alcohol, co-infection with B and HIV. But when you sit and think about a patient with hepatitis C, these factors really can't lead you to a good decision about where they stand. So again, we still rely on liver biopsy. I want to point out, however, again, that viral load should not be used to prognosticate nor to decide who should be treated. Now, we primarily treat patients to prevent progression of liver disease, but I do want to mention a couple of important points. The first is vasculitis, typically due to immune complex disease or cryoglobulinemia. This is a relatively rare phenomenon that occurs in some patients with hepatitis C. They develop cryoglobulins that can lead to membranous glomerulonephritis, vasculitis. It's a very interesting report. It's actually a recent report in New England Journal of Medicine showing that patients had low-grade lymphomas that responded only to hepatitis C treatment aimed at eradicating virus. They did not require chemotherapy. So this is a relatively rare phenomenon, but may be an important reason to treat in the absence of liver disease. PCT, porphyria cutaneous tarda, when studies were done to look at the prevalence of hepatitis C among patients with this condition, as many as 90% are hepatitis C antibody positive. So any individual with manifestations of PCT should have hepatitis C antibody testing. And anecdotally, eradication of hepatitis C virus does lead to a resolution of the condition. Now, oftentimes, phlebotomy is necessary due to secondary iron overload. I'd also like to point out that there is an association with type 2 diabetes. This appears to be a relatively strong association, but the pathogenesis of this is uncertain. Now, what about treatment? Well, there's really two syndromes that we see. One is acute hepatitis C. That is the acquisition of hepatitis C today. Now, the goal of any treatment there is to prevent chronic infection. I'll talk a little bit more about this, but this is primarily healthcare workers sustaining needle sticks where they have a 3% risk of hepatitis C seroconversion, and this may be an indication for treatment. In the setting of chronic infection, the goal has evolved to be viral eradication. Now, I use the term eradication instead of cure, but nonetheless, the data strongly suggests that what we are achieving in these individuals is a cure of the hepatitis C. There's no virus present in the blood, none in the liver, and there is a regression of liver disease on long-term follow-up. In essence, the virus has been eradicated. Now, when you achieve this, you can prevent histologic progression and presumably clinical outcomes. But the real goal of therapy is to prevent clinical outcomes. And as of yet, there aren't strong data linking cure with prevention of end-stage liver disease, liver cancer, but we expect that data to follow as subjects are followed further. Now, a quick summary of the patterns of response. We do use hepatitis C viral load to assess response to therapy. The magnitude of virus does help predict response. Some patients when receiving treatment have what we call a non-response or a partial response. Their hepatitis C viral load will fall, but does not become undetectable. A good response is when the virus becomes undetectable, typically within 3 months of starting therapy. So when these medications, interferon and ribavirin, are going to work, they work very quickly, within 12 weeks. What you hope to achieve is treatment for a period of time, usually 48 weeks, stopping therapy, and the virus never reemerges. And after 24 weeks, that's known as sustained virologic response. Now, some patients having relapse, the virus comes right back. So patients fall into 3 categories: non-responders, relapsers, and sustained virologic responders. A large category of what we deal with today is those who have failed therapy, where there are very few options, although I will talk a little bit about new drugs in development. Now, the NIH held a meeting in June 2002 where they convened for 2 days, and they asked the question, what is the most effective therapy for chronic hepatitis C? The answer was unequivocally pegylated interferon alpha 2A or 2B plus ribavirin. Peg interferon is a modification of the standard interferon that's been used for more than a decade. The standard interferon was given Monday, Wednesday, Friday, or thrice weekly at a low dose of 3 MIU. Peg interferon is given once weekly. It has been modified by the addition of polyethylene glycol to provide once weekly dosing and higher levels of interferon. Ribavirin is an oral guanosine mucoside analog given twice daily. Together, these represent the only as well as the most effective therapies. The consensus panel of the NIH looked at 3 pivotal trials. It's important to know when you look at the patients enrolled in these studies, it's a relatively homogeneous population. 95% were Caucasian. Yet I already told you that in the United States, there are very high rates among African Americans. And there are some that suggest they don't respond as well to treatment. In addition, they were screened very closely for comorbid diseases. So they don't apply to patients, for example, with psychiatric disease or active drug and alcohol use. Nonetheless, these represent the best data we have available. The 3 studies I'll go through in some detail. The first, PEG interferon alpha-2b, sold now under the trade name PEG Intron and Ribavirin. This study, published by Michael Mons in The Lancet nearly 2 years ago, randomized 1,530 patients to either standard Monday, Wednesday, Friday interferon plus Ribavirin at standard doses, 1,000 and 1,200 milligrams daily. The arm up top got what's called induction dosing, high-dose PEG interferon for 4 weeks, then a lower dose plus standard Ribavirin dosing. The middle arm is the FDA-approved dosing for this regimen, PEG interferon alpha-2b, 1.5 micrograms per kilogram, that is, based on body weight, plus a lower dose of Ribavirin. Now, those of you who do clinical trials will note that they change 2 variables, the interferon dose and the Ribavirin dose. As I'll talk about, that may have been a mistake. But these are the data that led to FDA approval. Genotype 2 and 3 is extraordinarily responsive to these therapies. Regardless of regimen employed, the sustained virologic response rate was nearly 80%. Among those with genotype 1, you see lower response rates. 42% achieved in those with genotype 1 taking PEG interferon at the higher dose plus Ribavirin compared to 33 and 34%. Now, when you combine these two, you come up with an overall response rate. But when you're talking to a patient, the overall response rates are really meaningless. The standard of care today is to get genotype and quote response rates based on what genotype the patient carries. Based on these data, this drug was approved for the treatment of patients with hepatitis C. Now, a second study, published by Michael Fried in the New England Journal of Medicine just a few months back, is similar, but a few differences I want to highlight. They have one arm that's the same. Standard interferon Monday, Wednesday, Friday, 3 times a week, plus standard Ribavirin. They compare this to PEG interferon, a fixed dose, 108 micrograms, plus placebo. This study will demonstrate the need for Ribavirin. PEG interferon plus high-dose Ribavirin, the standard dosing 1,000, 1,200, not the 800 used by Michael Mons and colleagues. And these are the data obtained. Now, again, you see the differences in genotype. Genotype 2 and 3, 76% with PEG interferon Ribavirin, and 46% for genotype 1 with PEG interferon alpha-2a plus Ribavirin, leading to its approval for this indication. But one of the reasons why I like to think about this study is what the absence of Ribavirin does. Now, at the end of treatment, 59% of the PEG interferon alone patients had a negative hepatitis C viral load. That is, they were end-of-treatment responders. But after stopping therapy, 50% relapsed, and the overall response rate was 21% versus 46 and 45 versus 76. Ribavirin has a critical role in preventing relapse, and Ribavirin should be used unless absolutely contraindicated. We'll talk about some of those contraindications. The one that's absolute is pregnancy. The other problem is anemia, and we'll talk a little about strategies to manage that. Now, another study that defined how we treat hepatitis C today looked at 24 weeks versus 48 weeks for those patients with genotype 1, 2, and 3, and also looked at that low dose versus higher dose Ribavirin. This study has not yet been published. The data demonstrated that for those infected with genotype 2 and 3, 24 weeks of treatment, that is about 5.5 months, is adequate, with response rates of nearly 80%. Equally as important, 800 milligrams of Ribavirin, or 4 capsules daily, was as effective as higher doses. The importance of this is that 24 weeks of therapy with low